Now I invite Dr. Monisha to give a talk on practical utility of genetic testing in glaucoma.
Hi, good morning, everyone. So we're going to shift gears slightly from diagnostics of clinical evaluation and imaging to glaucoma genetics. Okay, so this is the outline of my talk. So I'll start by highlighting the differences between single gene or Mendelian diseases versus complex disease, because this forms the basis of clinical evaluation and genetic testing. So as we know from twin and family studies, glaucoma is a highly heritable disease with genetic predisposition. And glaucoma can occur at all ages, and it exhibits both a single gene or Mendelian disease inheritance pattern as well as a complex disease. So what's the difference between them? So now single gene or Mendelian diseases are rare, and in here there is a single genetic mutation is sufficient to cause disease because it has a large effect size. And these genetic mutations can be passed on from the parents, and children can potentially develop the disease. So they do follow a Mendelian inheritance pattern of autosomal dominant, autosomal recessive, or X-linked recessive. Now, complex diseases, on the other hand, are more common, and here a single gene is not sufficient to cause disease. Rather, there are multiple genetic variants, and sometimes in combination with environmental factors that combine together to collectively result in disease. So a genetic variant is a point in our genome where we differ from one another. So now, early onset glaucoma, they follow the Mendelian inheritance pattern, and genes for them are identified from family-based linkage studies. Now, adult onset glaucoma, on the other hand, they are common diseases, and the genes for them are mainly identified through large-scale genome-wide association studies. So early onset glaucoma encompasses primary congenital glaucoma, juvenile open-angle glaucoma, and developmental glaucoma. So primary congenital glaucoma occurs in infancy. They're mainly sporadic. However, familial cases with autosomal recessive inheritance have also been described. JOAG, on the other hand, occurs from the ages of 3 to 40. They follow an autosomal dominant inheritance, and the most common gene implicated is the mutations in the myocilin gene. Now, Axenfeld-Rieger's and aniridia are examples of developmental glaucoma, and they have an autosomal dominant inheritance pattern. Now, adult onset glaucoma, like I alluded to, the genes for them are mainly identified through genome-wide association studies. There have been a lot of them for POAG, and to date we have over 300 genetic loci that have been associated with POAG. Now, PSEG, on the other hand, is less well studied. We currently have 8 genetic loci associated with PSEG. So we know all these genes. How does this, what are the implications of these glaucoma genetic variants? So again, this is different for early onset and adult onset glaucoma. So in early onset glaucoma, because these are single gene diseases, there are gene-based tests for diagnosis of disease. Now, adult onset glaucoma, on the other hand, as I said, the genetic variants on their own are not sufficient, they're insufficient to cause disease. Therefore, what happens with them is they can be, the effect of these different genetic variants can be evaluated together in order to compute what is known as the polygenic risk score. So this risk score is a number, it's a percentile, which is between 0 and 100, and depending on what the percentile is, you can then interpret it as whether it's high, moderate, or low risk. So a polygenic risk score, basically, it's a quantitative summary of a person's individual genetic risk for a particular disease or a trait. So an individual can have different polygenic risk for different diseases. The same individual, different polygenic risk for different diseases. So in this paper from Jamie Craig's group, which was published in Nature Genetics in 2020, they described the development of the polygenic risk score for glaucoma, and what they had utilized a multi-trait GWAS analysis of not just glaucoma, but also the genes for cup-disc ratio and IOP. And they looked at the performance of the polygenic risk score across different glaucoma outcomes. such as the age of diagnosis, the change in RFL, and the likelihood of trabeculectomy. And what they found was patients that had the highest polygenic risk score, they were diagnosed to develop glaucoma earlier. And they also found that with every decile change in the polygenic risk score, this was associated with an accelerated progression rate on the RNFL change. And also patients with the highest genetic risk score were more likely to have undergone trabeculectomy surgery. They also looked at a prediction of genetic risk score, and what they found was that those patients with the highest genetic risk score had a 15-fold increase in the risk of having advanced glaucoma. And when they incorporated these polygenic risk score into as a prediction for development of glaucoma, they found that it increased the predictability over and above that was obtained by traditional risk factors of age, gender, and family history. So glaucoma polygenic risk score is a new approach which can potentially facilitate development of personalized management by identifying those patients who are at increased risk. But however, we know that most of the GWAS studies were performed in patients of Caucasian ancestry. Therefore, the applicability to other ancestries, non-European ancestries, are still being evaluated. So how do we translate what we know of these the different scores or these genes, monogenic diseases, into clinical practice? Again, this is different for early onset glaucoma and for adult onset glaucoma. So what the AAO recommends for inherited eye diseases, which includes early onset glaucoma, is that it is only warranted if it will impact treatment or surveillance. So for example, benefits of genetic testing are for those family members so you can plan appropriate surveillance for those family members who carry the same genetic variants. But otherwise, for those who do not carry, then you can assure those family members that their risk for glaucoma is similar to that of the general population. So in addition to screening of relatives, gene-based testing for early onset glaucoma can also be used to confirm diagnosis, especially for those diseases that have similar phenotype but different inheritance pattern. And test selection can either be screen panels, but now with the cost of whole genome sequencing really drastically coming down, you can even order, which is almost the same price as screening panels. So as I had alluded to, early onset glaucoma, we can now develop what we call the polygenic risk score to stratify risk management, to stratify risk. But however, it's important to remember here that unlike for early onset glaucoma, polygenic risk score is not intended to be a diagnostic test. It's only intended to be as a risk stratification tool. And importantly, primary open-angle glaucoma is actually quite an optimal disease for the clinical utility of the polygenic risk score because it's highly heritable, it has no strong environmental lifestyle risk factors, it has a prolonged asymptomatic disease phase with irreversible vision loss, and studies have also shown that early diagnosis and treatment can actually lead to prevention of vision loss. And I think what is really exciting is that we now actually have commercially genetic testing to compute PRS in adult glaucoma that is commercially available. This has been around for a few months now. So I'm not sure if you're aware of this, but this is a company called Sionix Bio, which was founded by ophthalmologists and researchers in Australia. So I'd like to say, yeah, I have absolutely no financial interest or commercial interest in this, but I think as healthcare professionals, as clinicians, it's important for us to know what is there so that I'm sure we all have patients who ask us, are there genetic tests? So now we actually do have something for adult onset glaucoma. So this is a company that provides a service for generating a polygenic risk score, which is called the SITE score. And currently, it is available to healthcare professionals only in Australia and New Zealand. And so the population for which it can be requested are those unaffected individuals with or without family history of glaucoma, glaucoma suspects or ocular hypertensions, as well as confirmed cases of glaucoma. So what are the clinical uses? It can be used to predict the risk of development or the age of onset of glaucoma, and for perhaps ocular hypertension, we know from the AIOC study that treatment can result in reducing the risk of development of POAG. So perhaps for those ocular hypertensives with a high genetic risk, they can be, treatment can be initiated early, as well as perhaps it can also be used for confirmed cases of glaucoma when you want to enhance treatment depending on the genetic risk. So this is my last slide really is, I mean, polygenic risk score is not something new. It's been there, it's been around for heart diseases, some cancers as well as for diabetes. So I think it is something that, and now it's available for glaucoma as well. I think it is something that clinicians, I mean, we'll have patients asking us about this. So in addition to understanding the benefits, also it's important to know what are the potential risks and gaps. So these are some of the benefits of polygenic risk score, but there are also some risks which can arise from incorrect information as well as correct information. So what I mean by incorrect information is that, as with any other test, a genetic risk score can also suffer from imprecise risk estimates and false positive. So what is important is these tests should not be used as standalone tools, because perhaps if you use it as a standalone tool, a patient with false positive test, it can lead to inappropriate clinical actions. Therefore, they should always be used in conjunction with clinical examination and evaluation. Now, risks arising for correct information, this is mainly related to communication of results, because as I had alluded to, it's not unlike the test for single gene diseases, it is not a diagnostic test, it's a risk stratification tool. Now, societal risk really results from issues related to insurance or employment. And it's also important to understand that currently most of the polygenic risk score are applicable to patients of European ancestry. That's why, so currently it is being developed and evaluated in persons of other ancestries as well. So in summary, there's been significant progress in understanding the genetic basis of glaucoma. For early onset glaucoma, there are availability of gene panels to confirm diagnosis and screen relatives. And for adult onset glaucoma, we now have commercially available polygenic risk, of course, currently applicable only to persons of European ancestry. So what do we hope to see in the future? What are we likely to see? Is personalized risk management assessment, not only for primary prevention, but also to guide management decisions and monitoring. And perhaps we may be moving, well, not too much in the near future, but I guess in the future to move towards what is happening with certain cancers is pharmacogenetics, when prescribing glaucoma therapeutics in the future. Thank you very much.